Okay, so we have okay, so we'll start the discussion. So once again, good evening everyone. Myself, Dr. Rijul Agarwal. I'm the Orthodontic faculty at DAMS. So today we are going to have a discussion on the recently concluded INICET May 2025 exam on Saturday. Okay, so the paper this time had a chunk, you can say, if I can calculate it by percentage, it was approximately 15 to 20% comprised of ortho questions only. Okay, and they were all clinical based questions, nothing of such rote learning or something like that which you should have remembered, and they were all clinical applications of the subject. Okay, so we have people joining up. Good evening, Shalini. Okay, so the aim, as I've already told over multiple of my YouTube recall sessions, is not to pinpoint or find out or correct anyone's answer. Okay, what is done is done. The aim is for you to analyze and correct your mistakes so that they don't get repeated in future. Okay, because questions वही है, concept वही है. Okay, they just twist and turn and make and form new questions with new options. So our aim right now is to analyze the paper, analyze your mistakes, and not to commit them in future. अगर कोई concept is not clear, you can very well go back to your notes and revise it. Okay, and neither our aim is to pinpoint that ये पढ़ाया था, वो नहीं था, ये ऐसा था, वैसा था. Okay, if anyone has any doubts or kuch in understanding, just write in the comment section and I'll be able to help you out. Next, a big disclaimer which we all issue, that it's a recall based thing. Okay, so these are the questions which I got from the feedback from the students. Okay, and based on that recall we are having the discussion. Okay, so let's start. So the first question is, all are features of skeletal class 3 malocclusion except. Okay, so there are two questions which came in the exam. One was on skeletal class 3 and one was on skeletal class 2 or 3. They were varied opinions. So this is the first question out of it. So they are asking you about the clinical features of skeletal class 3 malocclusion except. So the options were increased overjet, prominent chin, protruded maxilla or hypoplastic maxilla, and a negative A and B. So a very easy question. Prominent chin would be due to a increased growth of the mandible. Retruded or hypoplastic maxilla means a retruded or posteriorly positioned maxilla. And a negative A and B, or you can say they can also write in their upcoming exam a and B value of 0 degrees, also indicated of skeletal class 3 malocclusion. So they are asking about except. So increased overjet is the correct answer here. So increased overjet is a feature of skeletal class 2 malocclusion. Okay, so the various question, so one thing leads to another. So the concept which should be clear with you is about the orthognathic surgical point of view, compensation, decompensation, what is the extraction pattern of camouflaging skeletal class 2 and class 3, camouflage options. So these 2 to 3 things should be clear to you from one question. Okay, and cephalometric parameters and values as well. So what is compensation, what is decompensation, what is camouflaging a malocclusion? Okay, next question. A 7-year-old child reported with bilateral posterior crossbite plus a constricted arch. Which appliance would you give? Now students, if any one of you could help me with this question. Now some students said that there was a habit also mentioned in the question, that the patient also had a habit of tongue thrusting in it. So if any one of you can recall whether this was given or part of the question or not, it will be of great help. Nevertheless, the answer won't change, but the concept which I'm trying to explain it to you would be of great help, because some said the habit was also mentioned, so they were not able to answer because none of these appliances would have been able to correct the habit. So some of the students left the question or did not attempt it. So if any one of you could help me whether the habit point was also mentioned in it or not. Okay, none. Anyhow, so the question says that the 7-year-old child means it's a growing child. The child was growing and he had a bilateral posterior crossbite with a constricted arch. So what appliance would you give to correct it? So looking at this question, it's a very straightforward question. You have to just correct the posterior crossbite due to collapsed or constricted maxilla due to transverse deficiency. So out of all these four options, the straightforward option with is the quad helix appliance used to correct or expand the maxilla. Okay, now if what based on the recall, some students said that there was a mention of habit also, that the patient also had a habit of tongue thrusting leading to development of lateral open bite. So let's us assume that this was also part of the question, that there was lateral open bite. So Shalini is saying yes sir, that I assume that you're saying yes for the mentioning of habit of tongue thrusting in it as well. So let us assume that the question also had a point of mentioning which said that tongue thrusting habit was also present leading to lateral open bite. Okay, so I'll explain the concept why quad helix would be the correct answer, but let us assume that you do not know and this habit was also mentioned. So looking at the options, lingual arch cannot be the answer. Why? Because lingual arch is given in the mandible and no appliance as such would be given, can be given to correct the tongue thrusting habit within the mandible. So this is ruled out. Cervical headgear, ये habit के बारे में याद नहीं है सर. Okay, no problems. So this is for those who just in the recall thing said that one student said that there was a mention of habit as well. Okay, so cervical headgear. Now cervical headgear cannot be also part because it is used for correction of or used for to extrude the its molars and correct skeletal classroom. Similarly, bionator. Bionator is also used to correct a functional or myofunctional appliance, correct class 2 or class 3, skeletal class 2 or class 3 option. So that leaves us with quad helix appliance only. Now how this quad helix appliance can be used or to modify correct this tongue thrusting habit is that this is the image of a quad helix appliance. Every one of you know how to activate it, which is the plier, that is a 3-prong plier which is used to activate it, the anterior and posterior bridges to correct anterior or posterior crossbite which is present. Now in the anterior bridge, certain spurs are soldered so as to correct the tongue thrusting habit as well. Okay, so this quad helix appliance can be modified to correct this tongue thrusting habit as well if it had been part of the question. Okay, so hence quad helix is the correct option or answer here. Okay, so they could have given you other 3 options to could have made it more confusing by giving other 3 options as something else or some other expansion appliances as well, but with the presence of this habit, only quad helix would have been the most appropriate out of all of them, because it can be modified with soldering of parietal spurs to correct the habit. Okay, moving ahead. So a question based on the application of biomechanics. Okay, which nevertheless made it sound complicated, but it was a very easy question. The question is, utility arch is given for the correction of deep bite. Its initial or primary effect would be. Now the options are extrusion of molars, intrusion of incisors, intrusion of molars, or tipping of molars. Okay, so first of all, what is a utility arch? We have discussed it, but I'm going to discuss it once again for the benefit of our audience who don't remember or not able to answer this question. So first of all, utility arches are of 4 types. They can be passive utility arch, intrusion utility arch, retraction utility arch, and protrusion utility arch. So these can be modified as per our convenience. So here the question is asking you about intrusion utility arch. Okay, now when we give intrusion utility arch, its primary purpose is to intrude the incisors. Okay, its primary purpose is to intrude the incisors so as to correct the deep bite. Now from our biomechanics classes, we have studied that for every action there is an equal and opposite reaction. So what happened? When we give an intrusion utility arch, it has a side effect of extrusion of posterior teeth. So at the same time intrusion is happening, and at the same time extrusion of posterior teeth happens. So this is in the one plane. Okay, now another side effect of this would be, so how do we intrude this utility arch? Just a minute. Okay, I hope my voice is audible. This is a very important question. Okay, biomechanically. Okay, so ये एक प्लेन में हो गया कि जब हमने इंट्रूजन यूटिलिटी आर्च लगाया तो उसने इंसाइजर्स को इंट्रूड किया, और उसका ही जैसे व्हाट वी हैव स्टडीड इज दैट देयर इज एन इक्वल एंड ऑपोजिट रिएक्शन ऑन द मोलर्स लीडिंग टू एक्सट्रूजन ऑफ मोलर्स. So there is intrusion of incisors, there is extrusion of molars. Now we'll look at the other effects. Technically, when the intrusion utility arch is constructed, it is constructed like this, and we forcefully place it inside the bracket, and it will have this effect on the incisors. वो ऐसे डाउनवर्ड होती है, we forcefully place it, and by the tendency कि वायर की टेंडेंसी होगी to go back to its original position, it will go back, and along with it will take the incisors inside it. Now ये जो फोर्स लग रही है, it is away from the center of resistance of the incisors. So what will happen? Whenever any force is placed away from the center of incisors, it will lead to creation of movement, और अगर movement create होगा तो it will have a rotation tendency, so the incisors will flare, so the anterior teeth proclination of incisors. This will be the third effect of intrusion arch. So अगर incisors flare हो रहे हैं या procline हो रहे हैं, what will happen? Equal and opposite reaction on the posterior teeth, so the molars will tip distally. So एक intrusion utility arch से see there are 4 effects which are happening. Now to further expand this concept, ये तो हमने हुआ front side से देखा. If we look at transversely, what will happen? यहाँ से intrusion utility arch जा रहा है, this is the center of resistance of molar. What will happen? force is acting here, it is away from the center of resistance. Again, as you movement will be generated, leading to lingual tipping of molars. Okay. It will lead to lingual tipping of molars. So this is all application of the concept of biomechanics. So हम करने गए थे intrusion of incisors, and this will all be the side effect of giving an intrusion utility arch. So the incisors can procline, the molars will tip distally, the molars will tip lingually, and there will be extrusion of molars. So these are all the side effect of intrusion utility arch. So why I am trying to explain you this is why, because right now they have asked you about one question. In the next exam this concept can be expanded and further things can be asked. I hope I am clear. If anyone has any doubt, can write or ask in the comment section and I'll be able to help you out. Okay, so as an orthodontist, what we want is intrusion, and these all effects are happening. So we need to first of all control these side effects so that only intrusion occurs. So what we do is, to prevent extrusion of molars, to prevent distal tipping, to prevent lingual tipping of molars, we give a transverse lingual arch. We give a transverse lingual arch so as to increase the anchorage value of these teeth. Either we involve the second molars or we give a transverse lingual arch to connect the molars of two sides so as to prevent these side effects. And how to prevent the proclination of incisors? We just gave up one couple system. That is, we loosely ligate or just place it. We do not ligate it or do not tie the wire completely with the incisor bracket. We just loosely ligate it so as to prevent the proclination of these incisors, so as to minimize these side effects. Nevertheless, howsoever we give this, some amount of extrusion, proclination of incisors, distal tipping of molars and lingual tipping of molars still occur. But the primary effect or the initial effect would only be intrusion of incisors. So its initial or primary effect will be intrusion of incisors only. The extrusion of molars will be the side effect, the distal tipping of molars will be the side effect, the proclination of incisors will be the side effect. They will occur, but as an orthodontist, our aim is to minimize these side effects and only achieve true intrusion of incisors. Okay, so this was a very easy question made tricky by this primary effect and giving you certain other options as well, so as to sound that कोई hi-fi सा question है, just to make you confuse and trouble you in the exam. Okay, so my basic aim was to make you clear with these concept as well. So I hope I am clear. I'll move ahead with the next question. So the biologic basis of orthodontic tooth movement due to mechanical stress or continuous forces is. So I got 5 options based on multiple recalls and multiple students. So I included all of them. So bone resorption, undermining resorption or necrosis of the PDL or bone, remodeling of the bone, osteoclastic activity or bone apposition. So simply this question is from biology of tooth movement, that a mechanical force or stress or continuous force is applied either through bracket or any means, orthodontic means, force is applied, how does the tooth movement occur? So it is through resorption, through deposition, through osteoclastic activity, or through undermining resorption or necrosis of the PDL or bone. Okay, so in general, the bone or tooth movement occurs due to selective deposition and resorption of bone based on the in the direction on which force is applied and how much movement and whether it's controlled, uncontrolled tipping or not. So coming to the options, it's bone resorption. No, it's not only bone resorption, there is deposition as well, so as to allow uniform movements of the bone. Undermining resorption or necrosis of the PDL or bone occurs in the concept of hyalinization when heavy forces are applied. And here it is said that there are continuous forces, not heavy forces. Okay, osteoclastic activity is necessary, but not only osteoclastic, there is osteoblastic activity as well. And bone apposition and reposition don't both occur at the same time, not only just apposition means deposition, both are. So the correct answer is remodeling of bone. So what is remodeling? That is selective deposition and resorption of bone so as to maintain the width of the bone. Supposedly this is a tooth which is embedded in the bone. Force is applied in this direction, there is deposition of bone, there is resorption of bone, and there is deposition of bone on one side. So उसी के opposite surface space and the tooth is moving in this direction. So that does not mean that this plate will continue to thin out. There will be deposition of bone on the opposite side, and here there will be resorption. So as a particular thickness of the bone remains the same. So hence its correct answer is remodeling of the bone. Next question. A direct question: after how much time should orthodontic treatment be started for a traumatized tooth with healed periodontium? In our class notes, we have discussed a lengthy table in which we have mentioned all the time frames for various tooth movement after how much time they should be started. Those who have read and the class notes would have been able to answer this question very easily. So this is just a part of that table. Okay, so it's written moderate to severe periodontal injuries with severe, which means severe lateral luxation, displacement, intrusion, avulsion and replacement. Ideally it should have been 1 year or at least 6 months when the periodontal healing has occurred. So here it said that with healed periodontium was the word given in the question, so 6 months would have been the correct answer. Another question, match the following. I haven't kept the options here. Okay, the ABCD option with various permutation and combination could be formed very easily. My aim, as I have told you, is not here to point out the who is right, who is wrong, but to make you understand the concept. So match the following habits with its outcome. A very easy question: mouth breathing, thumb sucking, tongue thrusting, bruxism. And on the right side they were anterior teeth proclined, spacing in the anterior teeth, and large adenoids and hypersensitivity and occlusal wear facets. Okay, so mouth breathing will be associated with enlarged adenoids. Bruxism will be associated with hypersensitivity and wear facets. Thumb sucking will be associated with maxillary teeth proclined, and tongue thrusting will be spacing in the anterior teeth. So whatever soever option 1, 2, 3, 4 in which all these match correctly would have been the correct answer. So this was all discussed, nothing much to discuss in this question. Next, another clinical based question. A 7-year-old child visited an orthodontist with a family history of hyperplastic or retrographic maxilla. Again, a class character class 3, what would be the treatment plan for this patient? The child is 7-year-old, an ideal age to modify the growth pattern. Okay, so start growth modification procedure as early as possible. Extraction of all primary teeth and wait for the eruption of permanent teeth. Not so, never. This would be wait and watch. Appliance of proclining maxillary anterior. Wait and watch. If we wait and watch, the growth period will go away. Appliance for proclining maxillary anteriors. This could have been the option had the growth stopped and the patient could be camouflaged just by proclining. Here the child is growing, so this is also eliminated. So we need to start with growth modification procedure, either with the face mask, with RME, with and without RME, to bring the maxilla forward. Next question, what is the amount of force required for uprighting, that is torquing of the roots? Options 35 to 40 grams, 50 to 100 grams, 10 to 20 grams, or 70 to 120 grams. So this is a table which we have discussed in the class, optimal forces for various procedures. So for root tipping, it's this translation. For root uprighting, 50 to 100 gram, rotation, extrusion, intrusion. A direct PVIQ question. Okay, so correct answer is 50 to 100 gram for root uprighting or torquing. So image based question was there. Okay, with the appliance for single anterior tooth cross bite was there. The question was asking you about how long should the retention be given. So instead of they are asking this time about the appliance, that is the Catalan's appliance for correcting the single tooth cross bite, they are asked you how long. Now the correction has occurred, how long that thing should be retained. So Catalan's appliance and anterior tooth cross bite is somewhat a pet question which is being asked in each and every exam, be it NEET, be it INI. Okay, so I think this has become sort of a habit or a favorite thing of the examiners to ask you about correction of anterior tooth cross bite. Now they have asked you about retention. So again, a very easy question from direct pick. We have discussed this multiple times in a class lectures, in our YouTube sessions. Okay, so these are the things which require no retention, that is anterior cross bites, dentations which have been corrected by serial extraction, corrections which are achieved by retardation of maxillary growth once the patient has completed growth, dentition in which teeth have been separated to allow eruption of previously blocked out teeth, and blocked out or highly placed canine in class 1 extraction cases. This was an image based question in I think 2023 NEET exam or somewhat, in which there were blocked out canines which were corrected and brought into the arches, and they asked you about how long the retention should be planned. So things which require no retention, these all examples are very, very important. So here for single tooth cross bite which is corrected, not needed, be it anterior or posterior. So next question. Which of the following is the best indicator of growth cessation? Or there was another type or another recall type which some said that which is the following is a most reliable or reliable indicator for assessing skeletal maturity of an individual. The options were hand wrist radiograph, dental age, chronological age, and height and weight. Okay, height and weight can never be an indicator for growth cessation, or neither it can be indicator for growing, whether the child is growing or not. Age and then chronological age and dental age have a very weak correlation with the growth status. Okay, they cannot tell you about a skeletal maturity of the patient. So the best would be the hand wrist radiograph. Now the hand wrist radiograph is even had the option would be have been CVMI or a lateral cephalogram. Here ना lateral cephalogram से हम क्या दे सकते हैं, the cervical vertebra maturity index. Then also hand wrist radiograph would have been the best out of this as well to assess the growth status of the individual. Next, hand wrist radiograph may be what you will see whether the growth status, whether the individual is mature or not, is you'll see the ossification of adductor sesamoid bone. Okay, so as I've told you, एक question से you can form multiple things as well. ओके, सो अगर लैटरल सेफ भी ऑप्शन में है या CVMI भी ऑप्शन में है, सर्वाइकल वर्टिब्रा मैच्योरिटी, देन ऑल्सो हैंड रिस्ट रेडियोग्राफ इज द बेस्ट इंडिकेशन और इंडिकेटर टू असेस द ग्रोथ स्टेटस ऑफ द इंडिविजुअल. नेक्स्ट क्वेश्चन, अ मल्टीपल आंसर करेक्ट क्वेश्चन, multiple options correct question. Okay, and the options were also varied. Some said this, some, so I included all of them. If I've excluded or forgotten or not included any, you can write in the comment section and we can discuss that as well. So what is the indicator for maturation or growth completion in girls? Or in females, which of the following is an indication of functional appliance treatment? Of females में maximum jaw growth is achieved until. So there were 3 varieties of question which I got. जिस भी variety का question आया, options और answer will change. So before discussing the question, we'll have just a background information. So this is a table from your textbook of Prophet, William Prophet. Okay, 6th edition, which we have discussed. So in girls, the onset of puberty or the ending of growth spurt is marked by the initiation of the menstrual cycle. That is comprising of the stage 3. So peak height velocity के बाद वाली stage is the indicator of end of growth spurt. Means you cannot go for functional appliance correction at this stage because the growth spurt has ended. Which comprises, so there are stage 1 and 2 for such individual. Whereas in boys, there are stage 1, 2 and 3, and in stage 4 means the growth spurt is ending. So these are the physiological features to determine the growth spurt or growth status of the patient. So what is the indicator for maturation or growth completion in girls? If we go with the first variety of question, if the first question came, so onset of menarche or onset of menarche means onset of menstruation period is correct here, means the growth status is complete. End of menarche is obviously CMI stage 6 is a fully grown adult. Fusion of epiphyseal plate just before puberty, no. Cessation of peak height spurt, yes. So A, B, C, D, F and G except E. If first variety of question came and these were the options. These are all indicators for maturation or growth completion in girls. Moving ahead. Females, which of the following is an indication for functional appliance treatment? So इनमें से कौन सा physiological feature you will look before initiating functional appliance treatment in a female? Onset of menarche, no. End of menarche, definitely no. CMI stage 6, no. Fusion of epiphyseal plate, no. Cessation of peak height spurt, no. Menarche occurred 1 year ago, no. So only E would have been correct, that just before puberty. You can go for functional appliance treatment if the second variety of question came. Or third variety, females maximum jaw growth is achieved until, so it's similar to the first one, so except E, all would have been correct. Okay, so had these been the option, the basic crux behind this is that in females the peak height velocity is a period where is the stage 2, or you have a year or so before you can initiate functional appliance treatment. Onset of menarche means the growth spurt has ended and you cannot initiate functional appliance treatment. Whereas in males, the growth spurt or the period of growth is quite long as compared to female. It is approximately 5 years, whereas in females it's 3.5 years. These numerical data is also very important. They have asked in exam how much time remains if the child is at peak height velocity, so you have 12 months or a year or so. Okay, so this table is very important for your exam point of view. We have discussed this in detail in the class as well, and they have asked you this time in a multiple option type question. Next, another question from biomechanics. When two non-collinear forces are applied on two teeth with equal distance, what will happen? Or what will be the outcome if two equal and opposite forces are not in the line of equilibrium? So two varieties of question. So this is a tooth. Two forces are applied which are non-collinear, means which are not in the same line. So one is here, supposedly one is here. Okay, with equal distance from the center of resistance. So equal distance from the center of resistance, what will happen? So the teeth will rotate. So this is exactly the definition of rotation. So how to cause rotation of teeth? To apply two forces equal in magnitude, opposite in direction, at an equal distance from the center of resistance. Okay, so what will happen? Rotation of teeth. Two varieties of recall which I got, both have the same answer, that is it will lead to rotation of teeth. Next question. Now some said this was when should serial extraction be timed, or someone said that the question which came was maxillary intercanine width is increased in which stage. I believe the second variety would have come, not the first one, because it would have been too easy. Serial extraction should be timed. That directly eliminates C and D option. Okay, and generally timed at late mixed dentition, not at early mixed dentition stage, because you have to give time for the premolar or the first premolar to erupt so as to extract it. So it's timed at late mixed dentition. Giving the second variety, that maxillary canine width is increased in which stage, would have been more appropriate. So if the question's first variety, when should serial extraction be timed, came, then it's late mixed dentition is the answer. Now maxillary intercanine width is increased in which stage? Now there are again two varieties. Increased at which stage and established at which stage. दोनों का ही आंसर अलग अलग हो जाएगा. और हाँ, अगर मैक्सिलरी पूछा है, अगर मैंडिबुलर पूछा है, so from one question we have 4 other questions which can be formulated. Mandibular increased and established, maxillary increased and established. All of this was discussed. We'll just have a quick revision. So in mandible, greatest tendency to increase is during eruption of lower lateral incisor, that is early mixed dentition. Age अपने हिसाब से you can formulate it. Maxilla में upper central incisors, that is again early mixed dentition. And when it's established in maxilla with the eruption of canine, that is late mixed dentition. On when mandible, it's established early with the eruption of lateral incisor, that is early mixed dentition. So what is important is क्वेश्चन में इंक्रीज पूछा था या एस्टैब्लिश्ड. आई हैव हेल्प्ड यू विद बोथ, जिसका जो क्वेश्चन जैसे आया था, ओके, एंड व्हाट कैन कम एज वेल इन द फ्यूचर एग्जाम. रिमेंबर सेफ्टी वॉल्व मैकेनिज्म. सो इंस्टेड ऑफ आस्किंग दिस, दे आस्क्ड यू इंक्रीज्ड एट विच स्टेज. So it increases in early mixed dentition and gets established by late mixed dentition in maxilla, whereas in mandible it's early mixed dentition is the correct answer. Next question, again a multiple answer type question, correct, and again a question in which I got multiple, two variety of questions. Some said that which of the following cephalometric parameters suggests skeletal class 3, some said it came was skeletal class 2 malocclusion. So we'll discuss both. So skeletal class 3 came, then A and B less than 0 or negative is the correct one. SNA 84, so this is of skeletal class 3 feature. SNA 84, this is a skeletal class 2 feature. SNB 82 is a skeletal class 3 feature. What is the normal value of SNA? It's 82, it's 80. FMA is not usually linked to either skeletal class 2 or class 3. Bits appraisal shows point A before point B, so it's an indication of skeletal class 3. So whichever question came, these are the correct options. FMA is Frankfurt's mandible plane angle, is generally not indicated or indicative of any skeletal class 1, 2 or 3 kind of malocclusion. Next question. So this was a question which came. So if some said that there was some more detail which was associated with this question, if anyone can recall it, will be of great help. The amount or the question which I got, I have put it up in my presentation to discuss with you. So in a 9-year-old child, the maxilolateral incisors are palatally erupted and a canine is missing. What could have happened to the canine? So the options which came were it got palatally impacted, it was not able to erupt due to arch length tooth material deficiency, or its path of eruption was blocked by the lateral palatally erupted lateral incisor, and fourth option was I am not recalled. So first of all, was this question correct, or if anyone can help me in recalling the complete part of the question? So I'll wait for a minute or so, otherwise we'll discuss this much only. Okay, so this was again a question which was, the topic was discussed in etiology of malocclusion. What is the reason of impaction of canine, whether it's buccal erupted or palatal erupted? So for buccal canine impaction, it is generally arch length tooth material deficiency. Whether it's buccally impacted or it's buccal erupted, it's generally due to arch length tooth material deficiency. And for palatally impacted canine, either it is due to missing or peg shaped lateral incisor. So students, if you remember from your ugly duckling stage and development of dentition, the roots of the lateral incisors are important to guide or to guide the eruption of canine at its proper position. If the lateral incisors is missing or improperly erupted, it can lead to problem in the eruption of canine. Okay, if the lateral incisor is palatally erupted, the canine could also get palatally impacted. If the lateral incisor, if there is not enough space for the canine to erupt due to crowding or something, the canine get buccally impacted or highly placed canine or buccally placed. If you remember, for such corrections, no rotation is, sorry. So coming back, sorry for the interruption, it got disconnected. Okay, as I was saying, if the canines are highly placed or got buccally impacted, it would be due to arch length tooth material discrepancy, means due to crowding. Okay, so due to palatally eruption or palatally erupted lateral incisor, the canine can get palatally impacted. If there is arch length tooth material deficiency, there will be buccal impaction of the canine. This question is somewhat missing or incomplete in its formation, or you can say in the recall. Had I got the complete question, I would have been able to answer you much better, but nevertheless the concept is this. This is already discussed in your class notes. Moving ahead, another match the following question, very easy question. You have to just match the cephalometric landmark with its correct definition. Nesion, point A, point B, and sella. So sella is lesion, is the anatomic landmark at the intersection of frontal bone and the two nasal bones on the skull. So this is nasion. Sella is midpoint of sella turcica in depression in which the pituitary gland is seated. Point A, deepest point between the anterior nasal spine and the procyon, and the last one which remains is point B. So you can make out the options using various permutation and combination. Next question, why RME cannot be done in a fully grown individual? A very easy question, direct question. Options were because of the complete fusion of the palatal bone, because of the complete fusion of circummaxillary sutures, and because of the complete interdigitation of the mid-palatal sutures. So for RME, C would be the correct answer. Agar, moving ahead, this question would have gone by face mask or by skeletal class 3 correction by protracting maxilla cannot be done in a fully grown individual. then what would have been the answer? Then the answer would have been because of the complete fusion of the circummaxillary sutures, not allowing the maxilla to translate forward. Okay, so another variety of this question could have been this. Moving ahead, which of the following is not a stressed trajectory of dentofacial skeletal? Okay, not a stressed trajectory of dentofacial skeletal. Options were lower border of mandible, condyle to symphysis, mylohyoid ridge, and lingula. So they're asking you about the stress trajectory of pillars based on the Benninghoff's theory, which we have discussed in the class. Okay, so these are the stress trajectories of the mandible. Okay, so out of these options, lingula is the correct, which is not the. So from lower border of mandible, from condyle to symphysis, from mylohyoid ridge. So stress trajectories are the pillars on which the whole support system of the head and neck is standing. There are various stress trajectories of the maxilla and as well as the mandible, which we have discussed in the class. So here lingula is the correct, which is not the stress trajectory. Again, another repeated question which we have discussed multiple times. What happens to the stiffness of an arch wire if diameter is double? So this is the formula. What happens on the strength, springiness, range if diameter is doubled? So stiffness or strength increases by 8 times, springiness decreases by 16th, range becomes half. And for length, strength becomes half, springiness and range becomes 8 and 4 times. This is the formula which you have discussed multiple times. You need to remember them. Next question, which of the following could be an indication of serial extraction? So I don't know, some said age was given, some said not given. So a 12-year child with crowding of 6 mm and retained mandible primary canine, 7-year-old child crowding greater than 10 mm in class 1, 7-year with interdental spacing, 7-year with skeletal class 3 malocclusion. So these are the indications of class serial extraction. Class 1 with discrepancy of 5 mm or more per quadrant, localized gingival recession in anterior teeth, ectopic eruption of teeth, and unilateral or bilateral premature loss of canines with midline shift. Contraindications will be mild to moderate discrepancy, that is less than 10 mm. Class 2 or 3 skeletal malocclusions, spacing in the dentation, congenital absence of teeth, open or deep bite, and extensive caries involving the permanent teeth. So here correct would be crowding of greater than 10 with class 1 skeletal arches. Another question, options were incomplete. If someone can recall those options, will be of great help. Following could be an objective of post-surgical orthodontic treatment. Options were aligning the teeth and correcting the dental malocclusions, or for stabilization of TMJ. So the objective of post-surgical means the surgically you have corrected, you have brought the maxilla and mandible at their ideal position. Now for post-surgical, pre-surgical objective क्या होता है? To decompensate, to correct the crowding, that is alignment. So for before surgery, all the teeth should be aligned and the crowding should be corrected. Post surgically, the objective is to settle the bite and to correct any minor alignment issues if still persist. Technically should have been done, space closure, everything should have been done. Post surgically, the main objective is to settle the bite. Okay, so if C or D में settling the bite या ऐसा कुछ option था, that would have been the correct answer there. So if someone can recall the option, would be of great help. Otherwise, settling the bite is the main objective post-surgical orthodontic objective for after orthodontic surgery. In certain surgery first cases, we correct the alignment and malocclusion later on, that is after surgery only, because here in surgery first cases we are skipping the pre-surgical orthodontic phase to take advantage of the regional acceleratory phenomena. We have discussed this in class. I'm not going to discuss those points. So if anyone can recall those other two options would be of great help. Otherwise we'll move ahead. Okay, so next question. So which growth phase coincides with the growth of maxillary and mandibular skeletal bases? It is same as peak height velocity. PHV stands for peak height velocity. It's before PHV or not related to PHV. So in the previous few slides, I have discussed and shown you the table in which growth phase of the girls and boys were compared, corresponding to stage 2 in girls and stage 3 in boys. So the growth of the maxillary and mandible or the jaws corresponds to the increase in the height of the individual. That is, it is same as the peak height velocity of an individual. So this is from our class notes. Remember the Scammons growth curve. The acceleration in the general body growth at curve affects the jaws and it parallels the dramatic increase in the development of the sexual organs. Had they asked you about maxilla and mandible separately, so maxilla approximates the neural body curve more and mandible the general body curve more. Next question, what does the term pitch refer to in relation to the dentofacial traits? So occlusal irregularity in frontal plane, occlusal irregularity in sagittal plane, midline discrepancy of the jaws, or vertical defects of the jaws. So this is the table which we have discussed. This is the figure from Profit. Okay, pitch, roll and yaw. Pitch is up and down deviation in the anterior posterior axis, that is in the sagittal plane, leading to vertical maxillary excess or deficiency, deep or open bite. Roll is transverse deficiency in the coronal plane, leading to canting of the occlusion, and yaw is vertical deficiency rotation in the axial plane, leading to mandibular deviation to right or left side. Okay, so occlusal irregularity in frontal plane, occlusal irregularity in the sagittal plane, midline discrepancy of the jaw or vertical defects of the jaw. So irregularity in the sagittal plane is the correct answer. Next question, a very important question in which again two varieties of the question, or you can say three, was given. That torque correction is done by which wire at the end of orthodontic treatment? Some said that it was not about torque correction, or you can say most of them said that it was not torque correction, it was about the maximum stiff arch wire during finishing and detailing, or the max stiffest wire at the end of the treatment. So students, this is, first of all I'll show you the table. So this is a table which is directly taken from the textbook of William Profit, the latest edition. Okay, so generally we use a 22 slot appliance, be it 18 slot or a 22 slot appliance. The stiffest or the last wire should be used is 2125 beta titanium. be it extraction case or a non-extraction case, and not a stainless steel wire. Why? Because finishing and detailing involves correction of root position or root parallelism. Remember the three stages. First, stage 1 of is alignment and leveling. Stage 2 is space closure if it's a extraction case, and stage 3 is a finishing and detailing. Finishing and detailing involves correcting the root position, and root position cannot be done with a stainless steel wire. It's always done with a TMA wire. So the maximum stiff wire which can be used during finishing and detailing is 21-25 TMA wire in a 0-2 slot. And generally we use a 22 slot appliance only. 18 slot appliances rarely to rare ever used. I hardly think it will be available in the inventory as well of any orthodontist. So for space closure, and again I said this time they ask you about finishing and detailing. If it had been about space closure, then it would have been an SS wire, either 1925 or 1725 depending upon the slot size. But for finishing and detailing, you need proper control. Why? First of all, why 21-25? Because it fills the slot completely first. You cannot afford to have any play between the bracket slot and the wire. Otherwise the teeth will move. You need a maximum stiff wire to hold the crown in its correct position, and at the same time you need to correct the root position, which can only be done with a TMA wire. So you need complete filling of the slot and correct the root position for the finishing and detailing. Okay, so this concludes our discussion. So there were a few 2-3 more questions that will be taken. One was on distal shoe, it will be taken in the pedo section. There was one question on the wires as well, TMA wire and all that, stiffness and all will be covered under the dental materials topic. So there were lot many questions this time from ortho. Approximately 15 to 20% paper was on ortho or ortho related topics only. A very nice clinically oriented paper which involved application. Some students said they had to, paper was lengthy, you had to read because there were multiple answer type and match the following type. The match the following one orthodontics were quite easy. There were one about cephalometric landmark, one about cephalometric and about habit. Okay, I hope this discussion was fruitful and advantageous for you, and it can help you in your future exams as well. If anyone has any doubt, you know where to reach me and connect with me. Okay, so study well and good luck for your future exams. I'll close the session.